Hi, good afternoon, everyone. Welcome to the APCD Quality Webinar. Thank you, everyone, for joining us. We're really looking forward to the discussion this afternoon. My name is Chelsea Jorgensen. I'm with the Minnesota Department of Health. And at this point, I want to introduce our meeting facilitator, Linda Green. Some of you are probably familiar with her from facilitating the workgroup meetings. And at this point, I will hand it over to Linda.
Thank you very much, Chelsea. Welcome, everyone. Good afternoon. This is the Minnesota APCD Data Quality Webinar, and I'm Linda Green from Freedom Healthcare. We have a number of people on the phone, so I'd like to do introductions for members of the APCD work group, and then we'll go into the purpose of this meeting and a brief overview of the agenda. So so we have some names of people. I see Mark Sonneborn. You want to say hi?
Hello.
Hey, Mark. Dr. Lee?
Hello. Larry Lee here.
Hi. Justin Bell.
Hello, everyone. This is Justin Bell from the American Heart Association.
Jim Mason. Okay. Have I missed anyone who's a member of the work group? Okay. Welcome to everyone then, and we welcome members of the work group as well as other interested parties. This webinar this afternoon has been scheduled by the Minnesota Department of Health as a resource to the work group members. As you probably know, the legislature directed this work group to address a set of questions about the future state of the APCD. These meetings began in August and will conclude in December. Will begin in July. The work group's recommendations will be forwarded to the legislature in a report early next year. The purpose of today's session is to provide information about data quality processes in APCDs to assist this work group in their work to develop recommendations to the legislature. We will begin with a presentation from OnPoint Health Data, the Minnesota APCD data collection vendor. Afterwards, we'll have brief overviews of 2 states with active data release and public reporting programs. We'll hear from Marilyn Kramer from Massachusetts and Jonathan Matthew from Colorado, and I'll introduce them more extensively later on. I'm going to ask that you hold questions and comments until after our presenters have finished. Of course, if you need a clarification, let us know. We're doing this because we've challenged our presenters to go through a lot of material in a short amount of time so that we will have plenty of time for discussion afterwards. If you do want to ask a question, please feel free to, during the presentation, please feel free to use the chat function. You can send your questions to, if you could please select all panelists. It's about the 5th choice down from the top. That would be terrific. I'm also going to, the chat function is at the top of your screen. It kind of slides down, and you'll see there's a little question box there. I'm also going to ask you to mute yourselves during the presentation. Please don't put us on hold unless you really want us to hear your on-hold musical selection. And with that, I'm going to turn this over to the OnPoint team. Janice, will you take it away?
Sure. Thanks, Linda. Good afternoon, everyone. I'm Janice Bergalt, Director of Client Services here at OnPoint, and also the Client Account Manager for Minnesota. I've been with OnPoint now for over 4 years. And previous to OnPoint, I gained my billing experience as Director of Billing for a large multi-specialty physician practice here in southern Maine. Also on the line, we have Sue Ann Singer, who was a previous client account manager for Minnesota for many years, and now is playing a role of more of a behind-the-scenes health data analyst. She has also worked for over 30 years with healthcare data and is one of the co-authors of the APCD submission standards that we use today. I also have Jim Harrison, OnPoint's president and CEO, on the line with us also. So in your slide packets that I hope were distributed, there's a number of slides about OnPoint. As Linda just said, we are tight for time, so I would highly recommend and encourage you to review this information. Included here is background about OnPoint Health data, and we've also provided some work examples that we've done. In addition, these are also good examples of analysis that can be accomplished with APCD data. So I would highly encourage you to review this. But for today's presentation, I'll be skipping to slide 11. And if you're working on the paper handouts, it's page 6. So on this first slide, I just want to distinguish between APCDs and MPCDs. So the difference being APCDs are all payer claims databases. You can see from the top half of the grid, it encompasses all the payer sources. Multi-payer claims databases include most but not all. Minnesota is in the more robust solution, being an APCD. But in addition to that, Minnesota is also one of the highest volume states in the APCD category, and actually the first one to start out with all payer sources right from the get-go. To speak to OnPoint's experience, we have implemented all but one of these 7 APCDs. The first step in submitting data to the APCD is registration. So on the top half, the bullet points there show you the criteria as far as those payers that need to register for the Minnesota APCD. Based on this registration information that we gather every April 1st, it's determined based on the criteria on the bottom half of the screen whether that payer then becomes a submitter. So in 2014, we had 241 registered submitters. Of those, registered payers. Of those, 90 became submitters. I also just want to add that if there are any questions for me, I'm not able to see the chat function during the slide presentation, so I'll rely on Linda or Chelsea to speak up if there's a question for me. So here are some additional APCD statistics specific to Minnesota. So OnPoint has been working with MDH since this Minnesota Healthcare Claims Reporting System's inception in 2009. OnPoint won the initial RFP bid at the end of 2008, and we were able to continue working with Minnesota since we won the bid last year in 2013. The collection of data actually began in 2009, but at that time we collected 1 year of historical data, so the APCD does include data from 2008 onward. We collect 3 file types, enrollment data, and both medical and pharmacy claims. The data that's collected was defined by statute. Through these years, we have collected more than 18,600 submissions and 4.5 billion records. Out of these 4.5 billion records, 71% belong to the top 7 submitters. And I wanted to note to all of you that we spend as much time on these top 7 submitters as we do everybody else. So every file, every submitter gets the same amount of attention and scrutiny when it comes to data quality. The bottom half of the screen, you can see the number of submitters. So over the course of time, we've had a total of 111 submitters. As I mentioned previously, currently in 2014, we have 90 submitters. The reasons for the fluctuation are mainly because of payers exiting the market, payers may merge with one another, new payers may come in, etc. So there's fluctuation over time. So our solution for collecting data we call OnPoint CDM, Claims Data Manager. It's both a public site and a secure portal. I've put the URL on the screen. You can visit the site, head to the client section where you're able to see links to Minnesota State's APCD legislation, Minnesota State Carrier Communication Manuals, which is the data submission guides that the submitters use. And then there's also general information and links to quarterly newsletters. Registered submitters can access the secure portal, and in the secure portal, they can submit their files, view the status of their submissions, and access their quality reports. Clients like MDH can also view the status of all submissions and can access compliance and data quality reports. So the first part of this, I'll go over data quality and validation. This is on the intake or the data collection side. OnPoint uses over 500 data quality checks. We start at the data element level, then we go a little broader and look within a file across data elements, go a little broader and look across files, such as looking at enrollment and claims and the relationship between the two. And then we look at trending, looking at the files and the submissions over time. I'll go over examples of each one of these. So this first report is our load threshold report. This first step looks at the data element level, whether the data element is complete and valid. So this column, the threshold column, this is the minimum threshold completion rate that was determined by MDH and is actually included in the administrative rule. This is the minimum percent of records that not only must be completed, but also be completed with valid codes. So as files are submitted, each data element is evaluated against these minimum thresholds, and the submission must pass all these thresholds in order for it to be accepted. The right-hand column here is the actual evaluation on this file. This submitter, it's a test file, passed everything just about at 100%, and one record at 80%. There are times where a submitter may not be able to meet this minimum threshold, either due to their systems where they're not storing the needed data elements, or if they have special considerations for the population they serve. So when these situations arise, submitters are able to request a variance. These variances are reviewed by OnPoint and approved by MDH. These variances also have a time limitation on them, as we expect that the submitter at some future date will be able to submit the necessary data. There's two items I want to point out here. If I can get my mouse. So the rel code, which is the relationship, this is the member's relationship to the subscriber, and the bottom one, date of birth. As you can see here, because we're looking just at the data element, the submitter did pass both of these data elements, completing it with valid information. We now head to our data quality report. This looks at data elements within the file, as opposed to the threshold report, which is more of a true-false report, whether the data is valid and complete. So here, again, we look at the appropriate use of the code, looking at the interrelationship. So a data element may pass the threshold requirement, which we saw on the first screen, where the relationship and date of birth both passed at 100%. And here you see where my arrow's pointing, this ID or data quality validation step, the average age of a dependent child not between 6 and 18. The result here, 41. So this is looking at the relationship between the date of birth and the relationship code, coming up with the value of 41 for dependent children, and SWES that shows us the data is suspect. There are some cases where it's a true error, which this one may be, and others that it may truly be accurate data, but we work with the submitters in working through these issues. All files also need to pass this step in order to continue through our process. The last report I'd like to share is our trending dashboard. This data validation report includes metrics such as per member per month. So this looks across files as far as calculating the per member per month. It also includes trending, where we look for variation in member counts, claim dollars, and claims supported by eligibility. All of these metrics and trends are evaluated both in total and by the product codes that are submitted. So through this data quality process, we work closely with submitters and support them as they submit and sometimes need to resubmit the data. This chart shows the percent of files that we've received each year and those that needed to be resubmitted. So during the onboarding process, we want to make sure that submitters start off on the right foot. So care is taken that the data meets these quality standards, and this process may actually take months. So you can see from this chart during the onboarding years 2009 and 2010, more than 30% of the files required resubmission, with more than 14% of these files requiring more than one resubmission. As submitters become more familiar with reporting to APCDs and the required data, you could see in 2013 where the percent of needed resubmissions declined to 18%, and the number of files requiring more than one resubmission drops to less than half at 6%. So some improvements on that front. So protecting patient privacy. Per the administrative rule in Minnesota, PII, or personally identifiable information, is required to be de-identified. To do this, we hash those data elements. The difference between hashing and encryption. So hashing is a one-way encryption. It cannot be unhashed, decrypted, even by OnPoint. Encryption, there's usually, with the provided key, you're able to decrypt the data elements. So in Minnesota, we do hashing, and like I said, we are unable to unhash the data. This hashing is, we provide the application to submitters, and they install it on their own desktop and servers, so that it's hashed prior to submission to OnPoint. We never see the live identifiers. We also have validations at our doors to make sure that the designated fields are hashed prior to load. These are the Minnesota-specific personal identifiable data elements that are collected. All of these are hashed prior to submission to OnPoint. I wanted to point out the date of birth. In the hashing application, we actually calculate the age in months prior to hashing the date of birth so that we don't lose the age for follow-on analytics. So files that have passed validations now continue through processing, where we standardize and process the data and consolidate it. So the next items I'll be going through is the creation of unique patient ID, provider ID, the standardization, an example of standardizing the data, and also an example of consolidation of claims. So creating the unique patient ID. I have three examples here. One with direct identifiers, the middle one with hashed identifiers. This is the Minnesota scenario. And the bottom one is similar to Minnesota, but with the addition of Social Security number. So the top scenario, using direct identifiers, when you use live identifiers, you're able to do what we call fuzzy matching, which means the John, J-O-H-N, and John, J-O-N, are similar enough, along with the other information, that even though this member switched plans, looking at the contract number in this example from Blue Cross to Aetna, we were able to assign them the same unique ID. When you're dealing with hashed identifiers, and again, this is a simplified example. Because the names are different, once it runs through the hashing application, it looks like completely different names to us. So on the hashed identifiers example, with the only match being a date of birth, that would look like two different individuals to us, and so we would assign two different unique IDs. The bottom example is what we do in some other states that also collect hashed PII. They collect the Social Security number as a hash value, and adding this one additional value gives you a match on two counts, the Social Security number and the date of birth. And therefore, we could designate this person as the same individual and assign the same unique ID. With that said, here's a survival analysis on medical enrollment. So overall, it looks very good. The first set of blocks here, what this analysis shows is in 2009, we counted all our members. So the first block, we have 100% of our 2009 members in there. The next grid next to it is showing the 93%. That is the same number of members, the 2009 members, still identified in the APCD in 2010. 87% are still standing in 2011, etc. Because the data is hashed, however, we're unable to investigate whether these drops are due to normal reasons of attrition, such as the member may have passed away, the member may have actually moved out of Minnesota, have become unemployed, or lose coverage, or if it truly is an issue with using hashed identifiers where a member may have switched plans and the new plan is reporting their information differently enough that it looks like a different individual to us. Oh, I also should have mentioned the purpose of creating this unique patient ID, of course, is to track a member across time, across payers, between pharmacy and medical, to gather all their health care costs. So it's very important to get that as accurate as possible. Next item is the creation of the unique provider ID. Basically follows the same path as member. The exception here is that we actually work collaboratively with MDH to create this master provider ID. Many folks thought that with the implementation of NPI for providers, that would solve all issues around creating a unique provider ID. We have found that not to be true. Even in current submissions, where NPIs are actually required on claims, it is not always reportable to the APCD, as there are many payers that still rely or use legacy IDs in reporting to the APCD. Also wanted to note that the creation of the unique provider ID is not the process of attributing members to providers, but actually linking providers together for analysis. So here's an example of standardizing the data. So in the Minnesota rule, on the pharmacy side, which is the left-hand side, they follow the NCPDP standards, which are the electronic standards for the submission of pharmacy claims. And you can see the codes for the relationship are different than what you see on the right-hand side, which are the standards used for medical ineligibility. So what we do at OnPoint is we accept the NCPDP standard and actually validate those codes against reference tables. But for follow-on analytics and for ease of use, we report out and standardize those codes to be the medical ineligibility codes. So someone using the data would not have to do the translation between the 01 and the 18 for self, for example. It would all be reported as 18. The crosswalks are stored in reference tables, and I also wanted to note that we do not change the data. we store the original data as submitted, but we create a new column with the standardized codes, and that's what gets delivered to analytics. So consolidation. Anyone who deals with billing and medical claims, and perhaps some of you have experienced it yourself personally, know that not all medical claims get paid correctly the first time around. And so we need to account for these adjustments in the APCD. So here's an example of simple aggregation. OnPoint actually has over 16 methodologies to consolidate claims, some of them specific to governmental payers, but we need to account for the various submitters' adjudication systems. And so there are, like I said, over 16 methodologies that we have built. This one is just a simple aggregation. So claim comes in, paid in February, and reported to OnPoint as data aggregator, paid at $135. In March, we see the adjustment. So the first line here is the reversal, where you see the charge and paid amounts have been negated. The second line is the resubmission of the claim, where the claim has now been paid at $155. What we deliver to end users is the final claim, highlighted here in orange, with the payment amount of the $155. In Minnesota, we found that 10% of the records are actually adjustment records. I highlighted claim status as an area that's a challenge for us in working with the Minnesota data. This is not collected on medical claims, and as you can see here, it designates claims as being primary versus secondary, so it would help with coordination of benefits. There are also codes that designate whether it's a reversal, whether the claim is denied, so those would also help with consolidation of claims. So the next step after all this processing happens is the actual extract process. During this extract process, we also provide what we call value adds. There are additional data elements or processes that help with follow-on analytics. So the first example I want to describe to you is the claim type. So claim type, what we do is basically group or label claims, identify them as whether they are inpatient or outpatient. And in Minnesota, we have 3 categories: inpatient, outpatient, and other. In other states, and we're currently working with MDH to expand the list for Minnesota also, we break the other category down even further into professional, labs, home health, and other type of providers, or other type of claims. Another value add I want to describe to you is the inpatient discharge grouping. Inpatient stays, depending on the length of stay, may span more than one claim. So what we do is we group all these inpatient claims together that equate to one stay and assign it an ID. That way someone working with this data would be able to group all that data together as part of one hospital stay. We also provide the reference tables, and in providing reference tables, we ensure referential integrity between all the tables. And the QA does not stop in the intake, in the data collection front. We do quite a bit of post-consolidation QA, data profiling, and again, post-consolidation trending. So in Minnesota, we also provide groupers, APCs for outpatient hospital, and the DRGs, 2 forms of DRGs for inpatient hospital. Some challenges and recommendations specific to Minnesota. So we went through additional patient identifiers when we're discussing unique patient ID, group name, adding that to the list as far as being able to track the movement of large groups. So when we're looking at our trending reports, if we see a drop in enrollment, we are able to work with the submitter, and at times they let us know that X group has dropped from them. If we collected group name in Minnesota, we would then be able to go find that group elsewhere and ensure that those members are still included in the APCD. Listing primary insurance indicator here as part of an enrollment data field that would help with coordination of benefits. Discharge date is currently not collected, and that would help analysis around hospital stays and also identify readmissions. Present on admission code, although we are applying and delivering MSDRGs as a grouper, it would improve the assignment of these DRGs. Claim status, we saw that on the consolidation example. And also pharmacy location is not included. So this would help with designating where services or people are getting their pharmacies, whether it's in or out of state. What we're currently working on these days, in addition to the collection of data, we are working with MDH to provide a data quality report. This is due for completion mid-November. Includes overview of on-point data quality steps, a lot of the trending and data quality analysis for enrollment in both medical and pharmacy claims. It's based on the most current extract that was delivered in June of this year, and we'll be updating this report semi-annually with every extract delivery. I also want to note that we're providing this quality report, and as I stated, it will be updated with every extract. But QA is never done. We're always studying the data with standard processes while continually looking for new ways to evaluate the data. And we always add these new evaluation methods to our standards. QA just can't be static in this environment as the healthcare industry is so dynamic. So we really need to keep up with it. And that is a quick overview of what we do. Were there any questions?
Hi, Janice.
Go ahead.
Did you want to wait to the end, or did you want questions now?
I think we can take some time for on-point questions now.
Okay. This is Mark Sonneborn. I'm with the Minnesota Hospital Association. Thank you for this presentation. Thank you for making time to be with us today. I found the information helpful. It looks like there's a lot of work done to make sure that the claims are complete and that you're trying to get the same person when you're linking the different records. I'm wondering, we have had some issues when the data comes to, particularly the hospitals, that it doesn't seem to jibe with the internal systems from hospitals. So we're wondering if there's anything that you do to see that the claims are accurate. And what I mean by that is not that all the fields are filled in or that it's the right person, but that the stuff that's being billed for is correct.
Can you clarify that a little bit more as far as what's being billed for?
Well, like I said, and part of this issue, I think, is a validation step that because all the IDs are stripped before they even get to you, that it's hard for our hospitals to verify their data, and when they get it back, there is seems to be off on some things. It doesn't match all that closely in some cases, and so either there's a methodology issue going on or the underlying data have a problem, and I'm trying to rule out the underlying data.
Yeah, so unfortunately with hash data, and I believe in Minnesota even the claim number is hashed. I could see how the reconciliation process would be difficult. Keep in mind this APCD does not include members outside of Minnesota. So if you have hospitals that are treating folks from out of state, those potentially would not be included, and also the uninsured. I'm not sure if that's...
we're aware of those limitations.
Okay.
Janice and Mark, this is Stefan Gildermeister, and I wondered if, Janice, you can talk maybe to another aspect of sort of APCDs. This is adjudicated claims, so that means by definition, claims that have been denied are not part of the analysis, so that's another aspect that I think one needs to be aware of. But I think parts of Mark's question, and I hope I interpret yours correctly, Mark, is in the process of consolidating the claims data, is there anything done where you are rejecting claims as inaccurate, where you are stripping claims from the submission, where sort of analytically you're making decisions to sort of say, this is not an accurate submission, and thereby sort of reducing the number of claims that would have been submitted by a health plan?
Okay, so depending on how the data is used for analysis, there may be instances of that. So one example I could think of, and Sue-Ann could possibly chime in also, we have a flag called orphaned claims. So there are cases where, for whatever reason, we're receiving a reversal of a claim, but we don't have the original claim. And so those may be left out of analysis when perhaps they should be included. Sue-Ann, do you have any other feedback?
I would say, thank you. They may be left out of analysis, but they're not left out of the extract. They are passed on. And I have been firsthand, hands-on involved in looking for those missing records, if you will, that we knew that the counts were lower. And we have scoured the database with the MDH staff looking at all the inpatient claims that were not classified or associated with Minnesota providers to determine if the linkage in establishing the unique provider ID was incorrect. And we did not find any fruit in that. And quite frankly, it's perplexing. As Janice mentioned, we do have the issues, of course, of the out-of-state patient and the uninsured. We also have situations, as Janice mentioned way at the beginning of our presentation, that there are certain thresholds that payers must meet in order for them to be required to submit data. All payers who are adjudicating claims in Minnesota are not required to submit data. Smaller payers are not. That could also be part of the problem. The only other area that is left, it would be the incorrect coding of the claim and not flagging it as an inpatient. And for us to flag it as an inpatient, we're looking for the bill type to be populated. So I don't believe that's happening. There's no reason to believe it would be happening because all of the payers are doing that. We would look for payers that are incapable of doing that, but everyone is doing that. So it's unfortunate that it's a mystery that we have not resolved yet.
So this is Diane Rydrick, another of the work group members. I didn't show up on the list because I'm here in the room. But just a question to Mark. So Mark, have you thought about whether there's additional sort of conversations that providers and payers might want to have about whether you feel confident that all claims that payers are submitting are reflective of the claims that should be there? So if we're exploring what our processes are once payers submit data, have you thought about that initial step in the process and whether you have an appropriate level of confidence that things are being initially submitted correctly?
You have to rephrase the question. I'm not sure what.
Yeah, sorry. I think we're talking about what happens once claims are submitted to us and the checks that are made. But is your concern that something is happening to claims that are submitted after they come into the APCD, or is any part of that a question related to whether everything that should be submitted is being submitted? So is it a question as much for payers or for data submitters as it is for us?
Yeah, it could be a combo platter there, because all we're seeing is the end result and trying to figure out what's going on.
So, and maybe to chime in on that, so the only data hospitals have seen, and I think you speak on behalf of hospitals, have seen so far is the various rounds of data that was produced under the Provider Peer Grouping Initiative. And I think as part of that, we can and we have shared substantial detail. So some of that detail, again, will be reflected in the quality reports. So we can, for any provider or health system that is interested in understanding how well its data are reflected in the APCD, we can summarize the data submissions for that health system and ask, who has submitted data by which product for which time period, and then sort of can assess if there are gaps, what they are. Are they due to federal payers who are not submitting data to Indian health system, to out-of-state patients? So all of that, I think, is doable. You and I have talked about how that would still be an approximation, and I think that is correct. But that level of granularity and investigation is something that we would love to engage with one of the providers, so that we might ask data submitters questions about potential compliance issues. So what Suzanne and Janice have spoken to is the trending analysis that they've done, and they've found at various times that certain claims dipped in a given month, and sort of we find that through analytics. But what we don't know is if certain classes of claims are missing sort of by design. If a query, if an original query was constructed and it has errors built into it, and the query will not be updated, those errors carry forward, and it may look artificially constant over time. So that's work. I think that would help us understand if there are problems. I should also say, and we've talked about this at the work group, Linda has presented the other plan for a quality report that we've talked about, where we hope to do exactly that, to look at enrollment records as we have them available at the health plan level and match them against enrollment counts in the claim submission. So that's another bit of information that I think will be available to anyone who wants to know more about the extent to which the data is not just largely complete, but fully complete.
Thank
but
you.
I think takeaway, Janice, the takeaway that was important that you provided was to say, if there are claims that cause concern, they are flagged, giving analysts and then the chance to say, well, for the cost analysis, we might drop claims that are artificially low, or claims that are orphan claims. So the claims are preserved, giving then the analyst the decision of whether or not to include flag claims in the analysis. And I think what we've talked about, again, the previous work of MDH on under the Provider Peer Grouping Initiative, there were, of course, a number of claims that were excluded to make the analysis robust and representative. So hopefully that helps.
Great. I have a couple questions from participants. What is the has the submission? What have been the submission issues? What types of problems lead to resubmissions, and what do you see improving after a resubmission?
So issues we see in submissions, going through the steps that we demonstrated or showed on the presentation, if data elements are not complete or valid, we have validations across data elements, which we have a number of those validations, and also trending. So in any of these circumstances, we do get back with the submitter, work with them. There are cases, like I mentioned, where potentially they may not have the data, and so they can request a waiver. There continues to be those type of limitations as far as the data that's available. I'm not sure what more to say from that.
So I think what I'm hearing is that there's a standard for determining when a resubmission is needed, and that there is a process for recording when the data submitter cannot fully meet the standard, so that we can document that. Is that a good summary?
Yes, and also, of course, we expect in the resubmission that the data has improved. And also we expect improvement over time. So what we've also seen is, especially in Minnesota, where the data collection, started in 2008, since that time, claims with the onset of the electronic claims has become more standardized. Adjudication systems have now stored more of the data that is required to be submitted to APCDs. So we're seeing improvements across the board as far as more data elements are being submitted and submitted accurately.
Great. I have another question. Could you talk a little bit more about the problem of non-NPI provider IDs? Do you have a sense of how much of the data comes in with a non-NPI provider ID?
I do not offhand. Sue-Ann, I'm not sure if you've dug into that detail.
Not recently. I haven't done it this year. I would say that there's two problems associated with the NPI. Just as you mentioned, failure to populate at all. The other confounding factor we're seeing in Minnesota are the systems, such as Alina. That's one that comes to my mind immediately, in that it is not uncommon to see an NPI and a name that both belong to the system, but they do not belong to each other. And in those situations, we get into a deadly embrace in that we can't trust either one. We don't know if the NPI is right or that the name that they have given, and therefore it cannot join the record that would actually represent that NPI with the correct name or the name with the correct NPI.
And Sue-Ann, can you talk a little bit more about how we're trying to overcome that? Certainly on the institutional side, on the hospital side, to look at other identifiers, and I don't know that I recall a number. Kevin, maybe you do, but there are thousands of combinations of what are seemingly valid identifiers that are available, that we sift through to create some uniformity, and I think we do a decent job with it, but sort of the tsunami of identifiers that is available and that is carried on records, or the variability rather of it, makes this linking providers across claims kind of difficult. Sue Ann, you can probably say that much better than I tried to.
Well, I think you did an excellent job, Stefan. I think you felt our pain. One of the solutions that I believe Kevin and his team came up with initially was to introduce what I consider to be trusted sources. And there what we do is that we're able to take the perfect record. So let's talk about the institution and what are the valid tax IDs for that institution. What names does it have? Of course, despite the fact that we're in an electronic age, we're still seeing old names for facilities that are no longer thinking that they're that name, but we're carrying all those. So we're building an external source of data as well about the hospitals, particularly the Minnesota hospitals, and using those to match against where a straight match, I'm not coming up with some of the names drawing them out of my head, but just a straight match on what, let's say, the licensing board would know as the name of that facility would be insufficient. So we're going above and beyond in trying to do that, and it's very much a partnership, too, where MDH is definitely the expert in terms of what's going on the ground there in Minnesota. And so they're able to assist in that, and we collaborate together as a team. But it's just as Janice said that validating the data is never done. It's not a static process. Similarly with linkage, we're constantly combing the database and looking for new ways to associate things.
Okay. I have another question from a member. On the challenges and recommendations slide, Janice, can you talk about, what are the severity, the extent and severity of these issues, and how you manage the issue list?
I guess the severity of the issues vary. The lack of additional patient identifiers as far as the SSN definitely would be beneficial, but you saw that the matching of unique IDs or patient unique IDs was still quite high in Minnesota. Group names, again, that is something that would be very helpful in trending and QA processes in the data, but we are definitely able to make do without it. We just have to do a little more digging into the data. Primary insurance indicator, again, that would help us as far as potentially deduplicating. So if we see a member with two different coverages, we're unable to distinguish which one's primary and secondary. It's easy if the secondary is Medicaid, because more times than not Medicaid is the secondary, but there are issues around that. A big one, I think, is claim status. So, again, if we have claims paid by the primary and secondary, in analytics, we try to rely on the claim that was paid as primary as far as looking at the dollars, so as not to duplicate the charges or duplicate the event. So without claim status, there are instances where we may be counting encounters twice. So, Joanne, any other feedback?
No, I think that works.
Okay.
Thank you, Janice, and thank you, On Point team. I'm going to suggest we move on to our patient experts from Massachusetts and Colorado. I want to assure everyone that your questions will be answered if you've submitted them, on through the chat function. We will provide an answer to them, and we'll try to get to them at the end. But we want to make sure that we get to hear from our colleagues in other states. So with that, I'm going to move on. I'm going to ask Marilyn Kramer to give us a little overview of the Massachusetts experience. Marilyn Kramer is the Deputy Executive Director of the Center for Health Information and Analysis in the Commonwealth of Massachusetts. She oversees the Massachusetts APCD at many phases of the development process, from data submission to product delivery. Prior to joining CHIA, Marilyn was the president of DXCG, a leading health analytics firm, and has extensive experience in the healthcare data world. I will say I've had the great pleasure of working with Marilyn, and she's really moved the Massachusetts APCD forward in a very, very short time. So with that, Marilyn, would you like to tell us about the Massachusetts APCD experience with data quality?
Hi, it's Marilyn from Boston. I'm coming to you from a rainy fall day here in the Commonwealth. I'm not, in terms of what to share with you, I think that I was thinking about when the former speaker was speaking from OnPoint. We do many of the same mechanics and processes that were described, but I think there's a bit of a twist on what we do. The first is to understand that our enabling legislation for the APCD was built on the concept of administrative simplification. The thought is that various state agencies would be using and are using the APCD to, in lieu of accepting reports from the carriers. So in other words, when the Division of Insurance would like to collect a report on HMO membership in the coming years, it will source that data from the APCD rather than relying on direct submissions as it has been doing for many years. Notably, we have been working with the Massachusetts Health Connector, which is our exchange here under the ACA, to implement a Massachusetts-specific risk adjustment program, and getting the data in and cleaned and edited on a quarterly basis in a production run has been a interesting challenge that we've taken on over the past couple of years. But we are sharing, I'm happy to report that we have been sharing results and simulation results with the carriers based on the APCD data. I should say the connector is sharing these results, and we are looking forward to risk adjustment settlements in 2015 based on the APCD, which leads me to the discussion about data quality. So prior to my arrival here at the state 2 years ago, a lot of effort had been spent on the various data edits and the thresholds and the structural quality that the OnPoint speaker discussed. However, what really turbocharged our efforts, if you will, is when we began to think about using the data for business operations. So, for example, in working with the connector on risk adjustment, we fed back, the connector fed back population counts and risk scores to the carriers. And there's a lot of money on the table, and the carriers took particular attention. This is no longer an academic exercise. There was money on the table. And, all of a sudden we found out that there was an insured PPO product that for some reason a major carrier had not been submitting data about. Similarly, as we began to bring on another state agency which provides insurance benefits to state employees. All of a sudden, one of its major carriers figured out that it was missing 10,000 retirees in its APCD submission to us. So as we develop business uses of the tool, we're finding that the data quality is getting better. And as you can imagine, we have spent a lot of time validating the results of the APCD analysis with the carriers. So, for example, we have visited with most of the carriers in conjunction with the Division of Insurance to share back with them membership reports by insurance market, group size, insured, self-insured, etc., so that we got the carriers to sign off that the analyses and the numbers that we were deriving from the APCD were valid and in future quarters could be used in lieu of their regulatory reporting to DOI. We've gotten enormous support from the carriers, both the regional carriers based here in Massachusetts, of which we have many, as well as the national carriers in our data validation efforts. And we are appreciative, but this has really made the data better for all. We have holes in the data. So I think I was on the line and folks were talking about people in border areas and hospital services rendered to people out of state, etc. We're finding, for example, that situs, which is an insurance term, becomes very important. For us, for example, we might have a Massachusetts resident, but he or she gets covered by their employer in New Hampshire or Connecticut or Rhode Island. And those people aren't necessarily those plans are not necessarily reporting to the APCD here in Massachusetts. So we've begun to understand geography a little bit better. And similarly, in Medicare patients, where the address of the Medicare best beneficiary may not be the billing address used by the Medicare Advantage plans. So again, once we have dollars on the table and business on the table, we start learning much more about the intricacies of the plans and how we want to collect the data. The topic that OnPoint raised about adjudicated claims data was right on point. We've spent a lot of effort. We call it versioning to get the highest version of claims, and we're still working on how to allocate a total claim to its respective claim lines. So say, for example, there was a claim for a medical visit, a lab, and an x-ray. How do we allocate dollars for various services within a claim? And we're still working on that to come up with something credible. Like Maine, we have worked on Master Provider Patient Index. Our data is fully identified. We have Social Securities on 70% of our population, so we're moving that along, and we've introduced that. And on Master Practitioner Index, which we're calling Master Provider Index, we agree it's harder than Master Patient Index, but we're making good progress. I think for us it's a work in progress, and we're working with our State Innovation Model Grant in the hopes of developing, to the extent feasible, a physician portal or a provider portal onto the Massachusetts APCD. But that is several years down the road. I'm happy. There was one interesting conversation that I heard from you all about validation of inpatient stays. I think the people from the Minnesota Hospital Association raised that issue. We did some work internally here within CHIA trying to validate the inpatient admissions seen through the APCD with our discharge data set that is provided to the providers. And we did pretty well with that. In addition to the issues that folks raised on the line, there was a very interesting issue, two issues. One is that a hospital medical record coder, which is the source of our inpatient discharge data sets, they see an admission based on their definitions. from a claims payment, it may or may not qualify as a separate admission. It may be a readmission. It may be an ER visit attached on to an observation stay. Again, it's very contractually based. And we're also finding that the hospitals generally have a hard time discerning between plan designs within a, say, for example, the Blue Cross plan. Is it really a PPO? Is it a POS? Is it an insured product? Is it an HMO? Oftentimes they do a good job at just grabbing the card and photocopying it and having that as a Blue Cross plan, but being able to tag it to a specific plan design within the, again, that comes out of their finance office, and then that to the claim and then to the APCD. So we've had pretty good success validating one against the other, but it's very hard to do, and we're approaching it more the validation from the business side and less trying to do it from the database to database in the main. So we're very excited about the APCD. As Linda generously said, we've made a lot of progress and milestones here in Massachusetts. The state agencies are ramping up to use the APCD, and we couldn't be more excited about the future work. I'm happy to answer questions that anyone might have.
Oh, thank you, Marilyn. I think we're going to have Jonathan talk, and then we'll move to questions for all three speakers. So let me introduce Jonathan Matthew. He is the Director of Data and Research for the Center for Improving Value in Healthcare, which is the Colorado nonprofit administrator of the state's all-payer claims database. Jonathan oversees the development of reports and public-facing website on cost and utilization. Prior to joining Civic, Jonathan was an economist for the FDA and taught at Georgetown University. I've also had the pleasure of working with Jonathan and have seen what he can accomplish in 2 years with getting a database from 0 to 60 in just that time. So, Jonathan, would you tell us a little bit about the Colorado APCD experience with data quality?
I'd be glad to, and it's nice to hear your voice, Linda. Can you hear me okay?
Yes, I can. Thank you.
All right. My name is Jonathan Matthew. I'm a PhD in economics by training. I am the Director of Data and Research at the Center for Improving Value in Healthcare, or CIVIC, located in Denver. As Linda mentioned, we went from, when I started with CIVIC in January of 2012, we didn't have a claim to our names. We went from that to public reporting based on the 8 largest health plans and the Medicaid agency in just about 10 months. And it was a wild ride, and we learned a lot along the way. And while I thought we'd learned a lot in that first year, the lessons just keep on coming, some of them enlightening, some of them painful, but all of them very positive. Colorado passed legislation back in 2010 to establish an all-payer claims database. That was a recommendation of a Blue Ribbon Commission on Healthcare Reform in Colorado. While the legislation was passed enabling an APCD, we didn't get a dime in state money to do it. CIVIC is an independent nonprofit. We were named administrator by the director of the Department of Healthcare Policy and Financing, our state Medicaid agency, so we're in kind of a unique position in the APCD world. We have had to go out and obtain funding from a couple of Colorado-based foundations to get the APCD up and running and see us through our first couple of years of operations. As I say, it's been an exciting time, and we've staffed up gradually over the last couple of years, and I think, a couple of years in, we're finally really beginning to hit our stride. Our legislation and enabling regulations require us to publicly report high-level, aggregated, de-identified information, highlighting variation in utilization and spending, incidence of chronic disease, cost to treat, and those kinds of things. We do that by county and 3-digit zip code. We stratify by age range and gender. And if you go to cohealthdata.org or comedprice.org, You can see an example of what we make available on that side of the website for free. To be perfectly candid, this information is mostly of interest to policy wonks and other data types. I use those terms in the most affectionate way because I am one myself. Recently, just at the end of July, we began to release comparative price and quality data for specific procedures on a named hospital basis. The price data that I speak of reflects median total paid amounts. So what you can see now on the website for vaginal and cesarean deliveries and total knee and total hip replacements, you can see median total paid amounts on a named hospital facility basis, along with patient safety measures, AHRQ patient safety measures generated by the Colorado Hospital Association, surgical site infection data generated by our Department of Public Health and Environment, and HCAHPS measures generated by the federal government. So right now, a consumer with a high deductible health plan, medical savings account, they're being encouraged to take more responsibility for managing. They can go to our public website and find median total paid amounts for those 4 procedures, along with quality indicators both from a patient safety, surgical site infection, and consumer assessment perspective. Over the next several months, or by the end of this year, we're going to add 9 additional outpatient procedures, mild and moderate complexity emergency room visits, and data on a named freestanding endoscopy and ambulatory surgery center basis. So people will be able to make a lot more meaningful comparisons, again, looking at comparative cost and quality data on a named facility basis. By the end of next year, we're going to add similar information for 15 to 20 imaging procedures, common CT, MRI, and X-rays on a named imaging facility basis, and then 5 types of physician office-based visits, new patient, wellness visit, basic office visit, continuing patient, that sort of thing, on a named physician group basis, along with quality indicators that we are developing in collaboration with the Colorado Medical Society, the Colorado Academy of Family Physicians, and various other physician stakeholder groups. We have had many of the same issues with data quality, completeness, validity, and so forth that were mentioned in the on-point presentation and that Marilyn highlighted in her remarks as well. To keep this brief, we work very, very closely with our data manager, Treo Solutions, now part of 3M Health Information Systems, and the submitters. Now we're up to 20 or so commercial plans submitting data to our APCD, along with the state Medicaid agency. We've been receiving Medicare Advantage data from the commercial submitters since the beginning of the APCD. And just one little correction to a slide I noticed in the on-point presentation, we currently have Medicare fee-for-service claims data under the state agency request process and data use agreement from CMS. We have that data for 2009 through 2011. We are processing 2012 Medicare fee-for-service claims data into the database, and we'll be requesting the 2013 Medicare fee-for-service data shortly after the new year. We've run into a lot of the same problems, as I mentioned just a second ago. We get fully adjudicated claims, but that still doesn't address the versioning issue. You find inconsistencies in primary claim control numbers across payer submissions, and we've had to work very diligently with the payers to ensure that we have the most up-to-date and complete information regarding a particular claim, particularly when there are revisions or changes necessary. We've run into similar challenges with an electronic master patient index or a master patient identifier. We've worked very closely with Treo Solutions, 3M Health Information Systems to correct that and get that information as good as possible. We do have the ability to track patients longitudinally across time in the database. We've had a lot of trials, tribulations, travails, and what have you with our master provider index. We've been working with Treo Solutions and a firm with a national reach called Clarity, and I know the Minnesota Department of Health has a very sophisticated process in place to ensure the accuracy of their provider information. As it pertains specifically to the reporting of hospital comparative price and quality data on a hospital or a named hospital basis, we ran into some data challenges there, and we worked very closely with the Hospital Association and some of the large healthcare systems in Colorado to overcome those difficulties. Once you take a hospital event, say a vaginal birth, you add up the facility, the professional, and the ancillary or other components, and you arrange all of those events in the data from high to low, you still see some weird things. You see some $0 amounts. You see some very low dollar amounts that don't reflect typical patient experience. You see some very high dollar amounts, similarly, that don't reflect typical patient experience. So we trim the top and bottom 2% off the distribution of all total paid amounts for that particular procedure before calculating or identifying the median. We calculate some confidence intervals around the mean of those distributions as well to get a sense of the spread or tightness of the distribution. But after you eliminate outliers that don't reflect typical experience, your claim counts or your total numbers of procedures, particularly hospital by hospital, might look a little low or quite a bit low in some cases. We also have the challenge that we only have fully insured commercial plan data. So we don't have self-insured plans, which is a little more than half of the claims activity in the commercial marketplace here in Colorado. We did work very closely with the hospital association and some of the hospital systems. Although we found very low counts of procedures in some cases relative to what the hospitals were able to generate based on their billing system information, we did find that the dollar amounts in almost all cases lined up very well. In other words, when we looked at the facility paid amount in our data, the All Payer Claims database, and we compared that to the facility paid amount that the hospital has in their records, we found that those numbers were very close and in some cases strikingly close for the most part. One quick point I'd like to make about validation, and then I think we should open this up to questions, is I'm not sure what overall validation or general validation means when you're talking about something as vast and diverse and complex as an all-payer claims database. I think claims data, we're all familiar with the shortcomings and limitations. Claims data is highly valid for a particular purpose or a particular set of uses. We're never going to get to clinical outcomes based on claims data alone, just as one glaring example. But again, when you talk about overall data validation, I'm not really sure what that means. I think you can track the quality, completeness, accuracy, consistency of submissions coming in from the payers over time to look for anomalies from month to month or quarter to quarter. That's an important aspect of our data validation. We bump our data up against the hospital discharge data, which the Colorado Hospital Association very generously shares with us. But I don't know that, I have a hard time wrapping my head around the concept of general APCD validation. However, when the APCD data is applied to specific projects, then I think you can have a very in-depth, detailed conversation around data validation using the data for a specific purpose or set of purposes. And I guess I would encourage people to think about that, to identify concrete examples when they arise, and to not just sort of set those examples aside, but to, very actively engage in trying to get to the bottom of some of the questions that will invariably arise as people apply this type of information to various types of research, public health, and payment treatment operations purposes. And I'll stop there.
Thank you so much, Jonathan. I'm just seeing questions for the moment from our chat list. We have a question about whether each of the APCDs has a technical advisory group that provide insight and information about or advice to the APCD about data quality and validation aspects and potential analytic questions versus methodology issues. Marilyn, could you speak to that?
Yeah, so it's a very good question. So the issue really is one of data governance, both on the intake as well as on the output in terms of uses and methodologies. Here in Massachusetts, we've created what we call a data intake governance committee. It includes the state agencies either using the APCD today or seeking to use it in the future, as well as representatives from the carriers that are submitting data to the APCD. And we use this committee to strike a balance between business needs or real needs of the state agencies using the data versus and the administrative burden on the payers for sharing, for providing the data. So, for example, when we added new data elements to support risk adjustment or to support the other state agencies substituting the APCD for their reports, the direct submissions, we worked with them to identify a list of new data elements that would be appropriate and that they could provide. On the data use case, in terms of using the data, we are using the governance committee and the state subset of state agencies using the data to develop business terms, common definitions for things like member months, as well as using addresses and other data elements that we need to share, definition of a discharge, for example, so that the various reports that are coming off of the APCD are lining up to the extent they can. We're also using this group to review requests for resubmission. So, for example, if a carrier wants to request a resubmission, but a state agency has already calculated shared savings calculations, for example, it will be up to this data governance committee to decide whether or not it's in the best interest of all the users to allow a resubmission by a given carrier. So this is a relatively new group for us. It's a work in progress, but the discussions have been very, very fruitful, both for the submitters and the users to date.
Great. Jonathan.
Yeah, we have the enabling statute created a 25-member or so APCD advisory committee in Colorado. This was, although the legislation itself is very general, the APCD advisory committee piece was really quite prescriptive. It didn't name people, but it identified 20 or 25 specific stakeholder groups that had to be represented on the advisory committee, and Civic was very small then. Linda Green was basically the APCD as far as Civic was concerned in many ways, and she worked very closely with the advisory committee for a year and a half or so to develop data submission guidelines and specifications, and that was done in collaboration with the payers. I know that we leveraged emerging standards for data collection at the time, but we came to agreement and consensus with the payers on what would be submitted and how. There was another group that looked at public reporting and what we might be able to release on the public websites and when. And then the advisory committee also was involved in a variety of data governance issues. We have a Civic board. Civic is about data and transparency in the APCD. We do a lot of work in payment reform. We do a lot of work in delivery system redesign. And the Civic board oversees the operations of Civic generally and weighs in on matters related to the APCD that is also has broad stakeholder representation. Internally, we have a data and transparency advisory committee, and they're local data experts, health policy people in the Colorado community that come together every couple of months to talk about development of the APCD, public reporting priorities, and things of that nature. We have a data release review committee that's called for in our enabling regulations. These are health data experts, people with extensive experience in HIPAA and high-tech and all matters privacy and security, and they've learned a lot about antitrust too, because we do have access to paid amounts at the claims line level. The Data and Transparency, or the Data Release Review Committee, reviews all requests for non-public release of APCD data. And in Colorado, we're able to release everything from a custom report that could be on our website but isn't yet, to a de-identified data set, to a limited data set, to, in some cases, identifiable information at the patient level. And we have actually fulfilled 2 requests for patient-identifiable information for Medicaid beneficiaries. That claims information was then combined with clinical data and is being used to facilitate the kind of combined claims and clinical analysis that we all, I think, believe is necessary to support meaningful change in terms of identifying opportunities to improve care. So I guess the takeaway is we have a variety of different groups that make up our governance structure that provide expertise and input in a variety of different areas, and I'm happy to share details of that outside of the meeting if people are interested.
Thank you so much, Jonathan and Marilyn. I have another question from one of our members. To what extent does each APCD allow for linkages to other source data, such as registries for vaccines, deaths, births, and so on? Jonathan, I'll have you go first this time.
In theory, anything is possible. In practice, we're really only beginning to explore some of these opportunities. We have enough PHI in the claims to allow us to identify a unique assign a unique patient identifier and match up new claim submissions to existing identifiers and so forth. The state of Colorado uses a different system for that. Our state-designated health information exchange uses yet another system for that. My understanding is that the technical challenges associated with getting those unique individual identifier systems to talk to one another are something that can be overcome. The privacy and security considerations, to my mind, are more significant, more compelling. Who collects the PHI from the two sources? How is that data combined? How is it de-identified or otherwise made available to support public reporting and non-public release? Who controls that data? Who owns it? Who's the gatekeeper? Who determines if something's an appropriate use or not? We have been working with the state and the Health Information Exchange. There are actually two in Colorado to try and make that happen. The strategy that's emerging for the next 12 to 18 months is to identify a couple of discrete projects, sort of narrowly defined projects that would bring claims and clinical and other information, vital statistics, for instance, together to support in-depth analyses around specific topics of interest. Again, those conversations have reached the planning stages. Overcoming the privacy, security, and technical hurdles that will no doubt present themselves are something that we haven't been able to tackle in detail, but we're very actively moving in that direction. And based on my understanding, it feels like something that we'll be able to demonstrate proof of concept on here in the not-too-distant future.
Marilyn, tell us about how Massachusetts is approaching this.
So our enabling legislation identifies several groups of users. I'm only going to focus on two of them. The first set of users are state agencies, and we are required to share data, including identifiable information, with state agencies to further their mission. So, for example, our Department of Public Health will be, not today, but in the future, be linking vital records with the APCD. They are already at work linking the APCD to the cancer registry, as well as a contractor of theirs is working on linking the APCD to a database of EHR data that looks at surgical outcomes with respect to cardiac surgery. So that's all in process. Our second, and then we are also required, although we haven't done it yet, to share identifiable data with providers for the purpose of care management and coordination. We have been approached by several well-regarded researchers who are not working for the state agency who have interest in linking EHR data for some of their cohort studies with all payer claims data, and we've not found a way to to work through the privacy issues, of which there are many, because as folks on the line know, the APCD is unconsented, whereas the EHR might in fact be consented, particularly through the hospital. So we're really working through on that issue. However, it seems to us that the vital records, the cancer registry, by our Department of Insurance is a very appropriate linkage and within the mission and spirit of our enabling legislation.
Thank you, Marilyn. So on point, folks, it would seem like a hashed identifier might preclude some of these linkages. Have you seen it work anywhere yet?
Yes, we've actually, especially in the state of Vermont, some of our analytic work there, we have linked to multiple data sources. State of Maine, we've linked to birth and death certificates. We've linked to cancer registries and with both Maine and New Hampshire data that was both hashed at the time. So we've had success around that. The key is that the other database also needs to run through the hashing application, and then we run it through our unique patient ID algorithms to match it up. So it is possible with hash data.
Okay.
Janice, can I ask, what's the match rate that you get on that linkage?
I'd have to get back to you, Stefan. Was that Sue-Ann?
Sure, thank you.
I was just going to say it depends upon I think it really depends upon the study. We've had some excellent match rates, and we've had some less than stellar, especially when you have situations where you don't actually know what your match rate should be. The cancer registry is one where you're not absolutely positive as to what your match rate should be because you're not sure that the cancer person is the patient is actually in the database. But when you look at, let's say, births, you're more likely. I remember some studies that we've done for the New Hampshire Department of Human Services where we were looking for foster children, and we knew those were in the Medicaid database. There we had excellent match rates. So it depends on whether the data should actually get 100% rate or not. That impacts it as well as the confounding factor of the hashing.
Yeah, thank you, Sue-Ann. That makes a lot of sense.
I do believe, though, that Minnesota would have an additional challenge for linking an external data source because you have that hashing of the date of birth, and that is not the norm for other states. And so that makes it even more challenging, lacking a date of birth, a distinct date of birth to work with those elements provides an extra degree of difficulty in matching to an external data source.
Thank you. I have some questions now about data release and governance. So could I ask Massachusetts and Colorado to tell us about, the pluses? The question was, what are the pluses and minuses of the representation model for the governance committees? That is, Massachusetts is primarily data submitters and state agencies, and Colorado, by statute, has a very broad representation. Marilyn, do you see any challenges or strengths from the way that yours is organized?
Well, so I didn't mention, we have Massachusetts has an analogous, similar committee to what Colorado is describing for looking at discretionary releases of the APCD. And that includes representatives from the Mass Hospital Association, the Massachusetts Medical Society, some of the key payers, members of the research community, privacy experts, etc. So we also have that committee as well that helps us on data release. I think both are necessary. In the end of the day, for us, to the extent that our APCD is built on this concept of state agencies coming together to use a common data set, it's really all about data governance, and that's important. On the data release side, we are very cognizant of the huge issues associated with public interest. Our APCD has submitted allowed paid charges, so the carriers are very concerned about users, possible APCD applicants possibly re-engineering their contracts because under this notion through the APCD. So we're constantly balancing the transparency and public interest reflected in our enabling statute with the realities of a highly competitive marketplace. So having the committees serve very different purposes, and we think that the representation on them has led to very rich conversation and really furthering the use of the APCD here in the Commonwealth.
Thank you. Jonathan, what's your take?
I think one of the things that served the Colorado APCD and Civic very well from the very beginning is having that very broad-based stakeholder representation. Again, we are required to make a lot of the information available through the public website at no charge to consumers. So I think, that statutory and regulatory requirement that we publicly report price, cost, quality, safety, and a variety of other measures in a manner accessible to a variety of stakeholders is an important part of the design of the APCD. I think, the other aspect of this is that Civic is an independent nonprofit. We weren't given any state dollars to do this. So we've had to be very entrepreneurial about thinking about ways to get data out into the hands of the public to support healthcare operations, public health, and research purposes in a way that generates revenues that allows us to sustain ourselves on an ongoing basis. And again, it's the very broad-based Data Release Review Committee that reviews those requests. So that's been, I think we've been, Civic in particular and the Colorado APCD have been very innovative in that area, in large part due to necessity. I'll leave it at that.
Thanks. So kind of like a follow-on question that's come from one of our participants is, well, how do you handle conflict of interest? Wouldn't it seem like there might be that the membership is inherently going to create that situation?
We haven't really run into that yet. I think we get hints and glimpses of that from time to time. Transparency is great when you're talking about it in theory or philosophically. We discovered in Colorado that looks, feels, and the reaction is a little different when you're putting out comparative price and quality data on a named facility or provider basis. The tenor of the conversation tends to change, and you hear a lot more challenges about data completeness, accuracy, validity, and so forth. But I don't know that we've run into direct conflicts of interest. The legislation and regulations in Colorado are very specific that we can only release data in a non-public way if there's a direct benefit to the residents of Colorado. So we've had some of the vendors out there come to us and say, give us your whole APCD so we can develop analytic products. And we have to politely say no because there's no direct benefit to the citizens of the state of Colorado associated with those kinds of data releases. So, that's just one example of a parameter that the legislature, governor, and regulations put around our data release. I think that helps a little bit in terms of avoiding conflicts.
Thank you, Jonathan. Marilyn, how does that work in Massachusetts?
I'm not going to. It's not conflict of interest. I think it's a conflict of interests, plural. So the example I will share is available on our website. But one of our regional payers recently applied for an extract of APCD data for the purposes of constructing a narrow network, a tiered product that would be highly acceptable to consumers. And it was a very, so on one hand, we had a discretionary application, meaning our data release regulations say that we don't have to give the data in this situation. However, the applicant presented a case that it was in the public interest, and I don't think necessarily the other payers, the other carriers, thought it was in fact in the public interest and thought that they were going to be that the applicant might be getting access to proprietary information. And so we used our data release committee to understand this. We also consulted economists and others, experts, to understand the implications. While we've not made a decision, I think the conversation about transparency and the interests of market participants was very helpful and fruitful, and it is still a work in progress.
Thank you. Did you mention, Ellen, that you have a conflict of interest policy out on your website?
No, not a conflict of interest. That is we have our data release regulations, which tells us when we have to share data and under what conditions, and when we cannot, and when it's discretionary.
When does a member of the data release committee or your data and governance committee have to recuse themselves?
So on the data governance, so both of those committees are strictly advisory committees. So they are not subject to the state ethics rules of any sort. They are strictly advisory. We have a general understanding that when an application comes in, say from a member of the Harvard School of Public Health, that the members of the Data Release Committee from the Harvard School of Public Health typically recuse themselves from the discussion. But we do not have an official policy on conflict of interest because neither committee is binding in terms of their decision-making process.
So is that stated in regulation that they advise and don't decide?
So the Data Release Committee is in our regulations and stated it's an advisory committee. And our Data Intake Governance Committee is not in our regulations. We developed it with a charter and in the best interest of a good government initiative. And she is in our role as a state agency as a convener around data. But that committee is not not envisioned in our regulations, nor subject to, and has really no regulatory authority. It's strictly advisory.
Thanks. Thank you. That's very helpful to understand their role. Jonathan, in Colorado, which committees do members have to recuse themselves? Do you have a policy on that?
The Data Release Review Committee makes recommendations to the APCD administrator on the appropriateness of requests for non-public release of data. The criteria that need to be met are there's a benefit to the residents of Colorado, and we interpret that in a AAA way, better care, lower cost, better quality. That the request is fully compliant with HIPAA, high-tech, and other applicable laws and regulations. And we're also allowed under the regulations to charge a cost recovery fee to support ongoing operations. Again, the regs specify a data release review committee, but make very clear that it's to operate in an advisory capacity, that they don't have thumbs up, thumb down authority over requests for data. From a conflict of interest perspective, the committee thought it wise to develop, as part of its own internal policies and procedures, a conflict of interest policy. Members of the committee signed a non-disclosure agreement. They're not to discuss what people are requesting of the APCD outside of Data Release Review Committee meetings or DRRC meetings. So there is a voluntary conflict of interest, and we have had members of the committee, again, it's broadly representative of a variety of different health data stakeholders, we have had people recuse themselves from discussions or making a recommendation for approval in the event of any potential conflict of interest.
Thank you. That's very helpful. I'm going to circle back to just use our last few minutes to circle back to a question that came in about identification. One of our members asked how the APCDs connect claims for patients who have medical claims and behavioral health claims from two different entities. Could you speak to that? I think this would also apply to pharmacy data and dental data as well, how the crossing across files works. Marilyn, why don't you start?
I'm not sure I understand the question.
Sure. So we've talked a little bit about master patient IDs. Is this allowing a database when it's fully implemented to link claims for an individual across different payers?
Oh, yeah, absolutely. Absolutely. And also, it's going to assist in our linking with pharmacy to medical services and dental. Generally speaking, though, we're finding that the attention to which the PBMs record patient identifying information, the various elements we need, is less rigorous than the medical carriers. But in fact, part of the goal of the MPI is to do that linkage.
Okay. Jonathan, is that about the same in Colorado?
It's similar. I haven't looked at the behavioral health aspect of it specifically, except as it pertains to Medicaid. Medicaid behavioral health services are generally provided by BHOs or behavioral health organizations under a carve-out capitated model. And because those encounters with the BHOs they're encounter data, they don't look like claims, they don't fit neatly next to claims, but we have all that information, and honestly, we haven't done an in-depth project trying to leverage those capabilities. Where we have run into some challenges is with matching pharmacy benefits up with medical benefits, because a few of the large plans in Colorado provide pharmacy benefits through a PBM, and it is not unusual to find a pharmacy benefit manager, CVS Caremark, for instance, using a different patient identifier than, say, Aetna, who relies on CVS Caremark for their PBM services. So we've run into some challenges there.
Hey, Janice from OnPoint, would you mind touching on some of the work that you've done in addressing that question for the Minnesota APCD?
Sure, this is Jonathan. This is mostly involved working very closely with CVS Caremark and Aetna and the other medical insurance companies that retain the services of a PBM to get them to move in the direction of better coordinating their submissions to the Colorado APCD and ensuring there's a crosswalk that allows us to match up the patient identifiers that are contained in those two sources of data. And it's been an uphill battle, and it's required a lot of convincing, but we've been making progress. So we devote a lot of effort at Civic and also at Trail Solutions, our data manager, to working with the carriers, the data submitters, to try and work out solutions to these kinds of issues. And like I said, it's a lot of time on the phone and a lot of persuading, but if you're persistent, that can pay off.
Thanks, Jonathan. Janice, could you talk a little bit about your work on that area?
Sure. We've done some recent analysis as far as behavioral health claims in relation to the medical claims. I don't have the statistics out front of me, but we did find that even with the hash data and the creation of the unique ID using hash data we were able to link members across payers, including those behavioral health carve-outs, to be able to link the members and their claims between medical and behavioral health claims. As far as the overlap in coverage between medical and pharmacy, we have about an average of 91% overlap of members that have medical and pharmacy claims.
Thank you. I'm going to squeeze in one more question. So, for Colorado and Massachusetts, who actually makes the decision related to use of the APCD in each state? If it's not the advisory group, who decides? I think, Marilyn, you touched on that?
I'm sorry to say, I actually need to get off the line. For the state agencies, it's by our regulations mandate data release. But for the discretionary releases, the decision is made by the executive director of our agency. But
Marilyn, thank you so much.
Good luck, Minnesota. Bye-bye.
Jonathan, do you have a two-word answer?
Not a two-word answer, but I can keep it brief. Again, the statute and regulations require that we make a lot of information available publicly through our website free of charge, and we have a number of data governance organizations I alluded to earlier that help guide us in making those decisions, but it's in large part up to the staff here at Civic to make those determinations, and the Department of Healthcare Policy and Financing and other stakeholders have opportunity to weigh in. When it comes to non-public release of data, the statute and regulations establish broad criteria, and the Data Release Review Committee that makes recommendations to the APCD administrator. So if a request meets those criteria and the DRRC recommends approval, and again, we strive for a consensus model there. We don't want to see a couple members of the committee saying no. We want to get everyone to yes and address all the concerns. It's ultimately Civic, the APCD administrator, that makes the determination, but again, under broad-based criteria and based on input from a multi-stakeholder group.
Excellent. Thank you so much. We are at the top of the hour, or some minutes past. I want to thank everybody for taking the time today to give us their thoughts, ask good questions, and give us feedback. Thank you very, very much, and I look forward to seeing the folks in Minnesota soon and other folks elsewhere. Thank you very much.
Thank you.
Thank you.
Thanks, everyone.